tuning in to my channel. If you are new to my channel, please remember to subscribe, to like, and also to share. My name is Isaac Simple and Real. I usually make this kind of presentations so that as a team we can be able to learn together and also expand our knowledge on how we can be able to do better and be able to manage our patients better. Today we are going to learn about drug-resistant TB new treatment updates. As we all know, previously we used to treat our patients using a treatment modality whereby our patients, actually the current one, we are treating our patients with multiple drug resistant TB for a period of 18 months. But we are going to learn on a short-term TB treatment modality for MDR, and that is a treatment for a period of 9 months. So let's learn and let's see this new drug that is being introduced in the market beginning the month of July. My name is Isaac, Simple and Real. Thank you for tuning into my channel. Kindly, if you are new to my channel and you have not yet subscribed to my channel, please subscribe, like, and share. This is a channel where we should talk about issues concerning averting HIV and sexually transmitted infection stigma in our society. And we usually say that being positive about HIV is not necessarily being HIV positive. Thank you. Let's learn. Okay, these are just but the objectives of what we'll be covering in our lesson today. Number one, drug-resistant tuberculosis. The diagnostic approach for detecting DRTB. Number three is discuss the treatment approaches used in on BPAL. We'll be able to understand what is BPAL. Number four is outline the management of special situations. Is detail the management approaches for adverse drug reaction associated with the second line and TB medicine. And lastly is to describe patient support strategies during DRTB treatment for sustained recovery. So guys, join me as we learn together. Thank you. Basically, this is just to make us understand on how tuberculosis is transmitted. As we can see on our that is on our right side, or maybe on our that is on our left side. As we can see, this is how you spread. Someone who is having active tuberculosis spreads TB. Someone who is speaking can release 0 to 200 bacilli while speaking. Someone who is coughing can release 0 to 3,000 bacilli, while someone who is sneezing can emit between 4,500 and 1 million bacilli. What does this mean? This means that when someone who is having active drug-sensitive tuberculosis or drug-resistant tuberculosis, when you have someone who is sneezing, the high likelihood of people in the household is almost 1,000 times higher than the someone who is coughing. So if you have a positive case or you make a diagnosis of someone who is suffering from TB and you have a complaint of sneezing, you must be very vigilant, because the likelihood they have transmitted the bacteria is very high. So the vigilance on screening the household contacts is very key. Also, the workmates, any household contacts. It's very important so that we are able to ensure that we do not leave these contacts who will eventually become drug sensitive TB or drug resistant TB patients in future before, if we are not taking caution. Remember, the caution here is that if you have contacts, you screen them for tuberculosis. If they are TB negative, what do? You start them on TB preventive therapy. And as we all know, TB is an airborne disease which can be spread through coughing, sneezing, singing, or talking. I hope we are together. Let's continue learning. Now, this is the natural history of TB infection. We start at the top, exposure to an infectious individual. This is a person who was diagnosed to be having tuberculosis, or contact with someone who was diagnosed with tuberculosis. 70%, they are not infected. However, they could be having latent TB. It's only that it was not active TB, and this is 70% of the contacts are usually are TB negative. We recommend for TPT. Number 2, the person had exposure and eventually became infected. This is 30%. Of 30% that got the infection, we have one side with primary or early disease, that is diagnosed with early TB infection, that is 5 to 10%. And of those who acquired the bacteria, containment, these are people who got the latent TB. Now, someone who acquired latent TB after exposure are 90%. Why? These people, it's because of the good immunity or adequate host immune response. So we could be having 10 of us, and one of us has tuberculosis. The person coughs. When that person coughs or sneezes, there is high likelihood cells will not acquire the bacteria. 3 of us will acquire the bacteria, but 10% or 5 to 10% of us who acquire the bacteria, there is a high likelihood they will get active TB disease. The rest of people, that is 90% or more than 90%, will get now this, what we call latent tuberculosis. That is because of adequate host immune system. Of these people, 10 people or less than 10 people may get a reactivation. Why reactivation? Someone who is having latent tuberculosis may get active tuberculosis in circumstances that their immunity is compromised, or maybe they have an immunosuppressive disease, either cancer or tuberculosis or malnutrition. I'm sorry. Niko live, tutaongea baadaye. Sorry for that. So this is what happens. Now, live with latent tuberculosis the rest of their lives without necessarily having any symptoms of tuberculosis. These people, some of them are healthcare workers, household contacts of people who are suffering from tuberculosis, and also it could be you. But because rarely do we test for latent tuberculosis, it's very hard to detect these people. let's continue learning. Now, what are the risk factors for TB infection in progression to active TB disease? Now, risk factors for TB infection. We have high prevalence of TB disease in population. Then we have smear positivity of cases in population or infectivity of cases. We have a type of TB disease, which is the cavitary or pulmonary infectious, which is more infectious. Proximity and duration of infection, cases contact. Environmental factors, that is a poor ventilation,